Live. Guys, welcome to today's live session. We've got a good one. We're going to be talking about a little story at the start of today's live session. I'll share the screen with you guys. We've got another set of x-rays to go through and a little MRI there. Hopefully it's going to be really helpful. I think the big thing, I put it in the title for today's live session, and that is, being bedbound after a relatively minor disc bulge. And unfortunately, these kind of things happen. And hopefully by sharing this story with you guys today, it'll help so many of you avoid this kind of scenario from occurring. And then obviously we'll go through the MRIs, and if there's any questions you guys have, you can post them in the comments. You can either post them right now or post them as we're going through things, and we will get to those very, very shortly. So I wanted to kind of set the scene for this story today on the live. And Maya injured her lower back, I think it was around about 7 or 8 years ago. And we've got an active person here, a young lady who's working out, doing stuff. It could be a young guy, right? It doesn't really make a difference. It could be an older person, right? No difference whatsoever here. And we're active, right? We're doing stuff. We're going to the gym, and maybe there's some things that could be a little bit better, but we're doing stuff every day. And we injure, and we get this bulging disc at L5S1, right? Bulging disc at L5S1. And we've got the MRI as well. We'll share it with you guys, and I'll talk about this a little bit later on, okay? But we've got this bulging disc at L5S1, and we get that standard advice time and time again, which is stop doing any resistance stuff, stop doing any high impact stuff for your herniated disc, because you're going to make it worse. You need to just stop all of that stuff. And I'm definitely of the opinion that in the first instance, we need to just take a step back and just say, okay, what's going on here, right? And if you were doing this kind of loading, we need to bring that right down, et cetera, et cetera. But that is a pause to then move forwards, right? It is not a step back, boom, 6 years later, we haven't reintroduced. And what happens for so many is that we have this injury. Maybe it's a minor disc bulge. Maybe we haven't even had an MRI, right? And that's not to say you need to for this. It's just helpful when we're talking about these kind of things to actually have some of the imaging to actually refer back to, which is one of the perks of doing these lives like this. And we've got the injury of the L5S1, and we begin maybe a little bit of guidance, and then it's just don't do anything too strenuous. So we get into yoga, we get into Pilates. And I think if I read the comment correctly in the members area, I was doing somewhere in the region of like 3 or 4 hours a day of just stretching, yoga type stuff, right? And this is the real problem, because this can't go on, because this did go on. It went on for a good period of time. And then 2 years ago from now, so 6 or 7 years ago, the start, and 2 years ago from now, we're at the point where we've had another flare up and we're bedbound. I think for 2 years, that was the status quo. And we can see how this happens. We have a minor disc injury to L5S1, which may or may not be accompanied with significant pain. We have a minor disc injury to L5S1. And because we're not given the appropriate guidance, over the course of the next 3, 4, 5 years, we are just getting weaker and weaker and weaker and weaker and weaker, to the point where the next time we have a flare-up, which, by the way, this is one thing to bear in mind, the MRI today, or the more recent MRI, which is the image just here. I'll just point it out to you guys. I'll share this with you guys in a second, and we'll go through the x-rays and everything. This is obviously the more up-to-date MRI. It's basically not even any different. The original MRI was a bit straighter, right? And that's just the virtue of how you're positioned on the bench with MRIs, which is why we don't infer a lot of alignment comments from the MRIs, because you're lying down, right? But it hasn't significantly got worse, the lumbar spine, on the MRI, before and after, about 5 or 6 years apart, if memory serves correctly. Yet in the latter part of that, for 2 years, we've been practically bedbound. Because what's happened is, by doing the yoga, the Pilates, etc., you are building no resilience into the lumbar spine. And as we've mentioned time and time again, the average adult spends a significant amount of time sitting down every day. And the average adult also spends very little time actually doing proper strengthening work. So for a lot of us, we don't have a lot to use. And I'm going to contrast this with another example of a guy that we saw at the clinic here, who's I also train with at jiu-jitsu, or have started training again with more recently because of this. And he had a very bad herniation. And I would suggest it was significantly worse than what we see in this particular case. Because I've seen the MRI of that particular herniation. And for that individual, his rehab relatively early, I'm talking very early on, right? He was doing like 70 kilos on the squats, right? Very, very out of the ordinary case, a very out of the ordinary case, because he has a background in powerlifting, a very big, strong guy, got injured, got advice on it early, and then was able to avoid this kind of scenario where we have the advice to stop doing anything. And then Maya's there losing muscle mass, because if you're not building it, right, the stuff from here down is very, very responsive to training, because the body knows that if my legs don't work, right, because I've challenged them too much, we need to make them stronger. If the back doesn't work, we need to make it stronger, because if we don't, that's terrible for our survival, right? And so people will find, in the weightlifting space, legs tend to respond very, very well to training. But there is a lot of muscle mass down there, here down, the buttocks, hamstrings, etc. There's a lot of muscle mass there, and it's expensive to maintain healthy living tissue. So if you are not using it because you've gone to a well-meaning individual who said, hey, you need to not do any resistance training, just do yoga and Pilates for the next 5 years, you're going to lose what you had. And then when you get successive aggravations and flare-ups of that, you're going to find you are less and less capable of dealing with that. If you've still got a nice strong bit of muscle mass, you've really got a lot of that protection in place, which is why it's so important to get the right kind of guidance, right? As opposed to the falling into that trap of flexibility, bendy, twisty. I say all the time, right? I say to you guys, don't do forward bending. Don't do your knee hugs. Don't do your child's pose. Don't do all of that stuff. Saying and knowing full well that it feels nice in the moment, but you get hooked on doing it, thinking it's helping the problem and not realizing it's making you worse. And so then when we fast forward, we get to the point where we're bedbound, we're not doing very well. And Maya said in one of the comments, and I wrote it down here, a literal direct quote. She said, when I began, this is the program now, so a good number of years later from the original injury, when I began the program, my spine couldn't bear its own weight. Now she's now flirting with 30 kilos on the squat and doing very, very well, might I add, in terms of the techniques. Great, she's worked really hard, to build that back up. But the point is, for a lot of you guys, you don't have the luxury of losing what little muscle you do have. And Maya said, "Yeah, that's awesome." Maya, I wanted to ask you, as soon as you're with us, have you ever been told you've got anterior pelvic tilt or anything? I'm just curious, because I wouldn't be surprised if you had. And we'll talk about that in a moment when I'm going to pull up the x-rays. She said, I lost more than, wait, let's pop this in here. Was it? Absolutely true. I'd lost more than 10 kilograms of muscle in the second year of being bedbound, to the point my back was so weak I couldn't stand on my feet. Like, it's terrible. What's terrible here is that this is not a significant injury. It's not a significant injury. That's also important to pass out. The effect on Maya's life was significant, but in the grand scheme of things, this is not a significant injury. And we see this too often. We see individuals with a relatively minor disc bulge. It's worth adding, the disc height there, even now, is still remarkably good, in spite of the fact that, yes, it's grayed out, yes, it's dehydrated, it's still got a good bit of space to it. And we see so often people coming back with minor changes on an MRI, not that much going on the MRI. And they're in a lot of pain. It can happen. It happens when the injury is dealt with very, very poorly. And so don't be disheartened if you go and have your MRI imaging and it doesn't come back with something that, quote unquote, explains why you're in so much pain, because you thought I should have like 3 herniations and like a bone somewhere out of place somewhere, and you've just got a bit of minor degenerative change at L5S1. That doesn't take away from the fact that the injury can still be painful. And it can be managed very poorly, unfortunately, if we don't get the appropriate guidance. So I'm just going to have a flick through some of the comments here, and then we're going to jump into the screen share of the images. So what have you got here? Just seeing some relevant ones. Leo said, Mike, physios don't have the same knowledge as you. Also, why don't they accept the neutral spine? Just because it's not their wheelhouse. They haven't learned about a neutral spine. Physios, generally speaking, are going to be trained to operate in general, right? Shoulders, knees, hips, and then it's down to the physio to choose to go down a line of specialty. I'm speaking from ignorance here. Just because the physio joins the spine unit or the spine rehab section doesn't mean they are an expert in the spine, right? They have to act like, when you join, you're not the expert. When you join, you might then get exposed to additional training, but they are just the physio that's providing you this list of exercises, right? And that's not to disparage all the physios. It's just to make a statement of, if I open my clinic one day and say I'm a specialist in horses, right? People are rightly going to say, well, Mike, what have you done in the equestrian industry? And I'll say, well, nothing. But I just thought I'd say I'm in that part, right? That's the way it is, right? Unfortunately. So hopefully that makes a bit of sense. even with a bit of a random example. What else? Can I drop you a message? Yeah, you can send a DM, guys. That's no problem. Okay, let's jump into these. Someone said, your doctor can diagnose and treat your disease, but they cannot change your life because that's your responsibility. There's a very good comment there. It is a very good comment. You know, the problem is, to that specific comment, is that unfortunately some medical people will take your problems. I will fix your problem, and here's the bill, right? And that's, you know, there's some not so good sales strategies, let's say, in that space, which aren't particularly desirable at all. But equally, all too often, we want to pass our problem to someone else. Just fix it. Just take it away from me, right? And you have to understand that with back problems, a back problem is a you problem, meaning you are perpetuating the problem. You have caused the problem. Maybe there was a bit of accident involved. I understand that. But generally speaking, back problems are a you problem. And what that means is you must be a part of the solution. It's a very empowering position to be. It's a very empowering way to think about it. But you are empowered. You are called upon to actually be a part of the solution. And that's a non-negotiable, right? You're not going to get better if you don't become part of the solution. So coming over to the x-rays, guys, I will come back to comments, keep them flowing in the comment section, and let's go here. So let me get my pen out. I've actually kept the x-ray that we did on Friday, I think it was, because there's some similarities here, which I thought worth mentioning. So what we've got here with Maya, check my pen's on. No, maybe not. And Maya, if you've got any questions, throw them in here. This is why this case is, you know, even better in that case with regards to what we've been talking about on this live session, right? We've got the lumbar MRI through here, right? We've got the big white spaces on all the discs, and then we've got the L5S1, great. And this looks fundamentally almost the same as the one from a good number of years ago, right? They look pretty much the same. The only difference in the old one is that Maya was evidently put in a flatter position. And Maya, was that yes and always to my question about anterior pelvic tilt? Please just say yes or no pelvic tilt or something like that if you've been told you've got anterior pelvic tilt in the past. But the MRI, there's not too much to talk about on the MRI, generally speaking, right? We can see where the issue is, the L5S1. When we are looking at the standing image, this is the important part that we want to really talk about. And so what we've got here is we've got the lumbar vertebrae are all stacked on top of one another on the sides here. And then we've got the sacrum, which is the triangle bone at the bottom. You've then got the two hip sockets here and here, and you can see that they are vertically aligned. Yes, so this is a great arm. I'm so glad. This is will be a really good X-ray example, right? So just to clarify for everybody, Maya has regularly been told that she has anterior pelvic tilt. Okay, why do we want to know the tilt of the pelvis? Because the tilt of the pelvis dictates the tilt of the sacrum, right? If the pelvis tilts one way, then the sacrum now creates a base for the lumbar spine to stick on, which is a very steep slope, which means it's trying to fall off, which creates shear. If it's tilted the other way, maybe not quite that much, but posterior pelvic tilt, it's now compacting, it's squashing down. All the weight shifts onto the disc in a different kind of way. This is more compressive, less shear, but either are not helpful. The L5S1 disc is slightly wedge-shaped, which means it's designed to sit on a roughly 40-degree slope for one individual. Now, what we see in Maya, let's go over to the X-ray again. What we see in Maya is that she does, if we look at the vertebra, okay, so we've got the green line. There's a little bit of disparity from the green line. We see the hips down the bottom here, hip 1, hip 2. And we see the center of mass here is running almost in between the two hips. So I would make the case that this is pretty well aligned. And it just so happens that we were talking the other day on the last 3 X-rays we've reviewed, for some reason, we've had all 3 have been atypical, meaning that the person's pelvic setup, the way in which the sacrum sits in relationship to the hip joints is such that it requires a slight modification in how much curve the individual should have, either a little bit more or a little bit less. The one 3 times ago was a case of needed a little bit more curve. The last 2 have both been that the individual needs a little bit less curve than the average. And so in Maya's case, this is 30 degrees of curve. So wherever it says 40, just insert 30. So the key numbers that we're looking at here are this number here. This number, this 40 degrees here, represents the total curve through from L1 down to L5. The way in which we get that angle, just for those of you that can't remember or haven't joined before, is we take a line along the back of L1 and we take a line along the back of L5 and we measure this angle. That should be 40 degrees. Well, in Maya's case, she should be aiming for 30. Okay. The next angle that we look at is what's called the sacral base angle, which is the line along the slope of the sacrum. It's the base that the lumbar spine sits on. And in Maya's case, this should be 30. It is also exactly bang on 30 degrees. Okay. This is how we decide whether Maya, when standing, has an anterior pelvic tilt or not. It just so happens that she is exactly where she needs to be, which you would go figure, right? Because if you tilt the pelvis posteriorly, right? If you tilt the pelvis posteriorly, from the neutral, this is from the neutral, right? So if we assume we are aligned correctly and we tilt the pelvis correctly, we tilt the pelvis posteriorly, we move the hips forwards of the center of mass. If we do the opposite, we tend to move the hips backwards of the center of mass. Generally, there are some caveats, but generally that's more likely to happen. The lumbar spine is pushed forwards of where the center of mass is. Okay. And so what will happen is Maya will see a number of well-meaning physios, chiros, osteos, whoever, right? And they say, oh, you've got an anterior pelvic tilt, you need to do a posterior tuck. No, she doesn't. No, she doesn't. She's exactly where she needs to be. And also, generally speaking, I know we've had a few examples to the contrary on the x-rays of late, but generally speaking, assume that you as a human being have a normal spine. Unless you have categorical evidence to suggest to the contrary, ignore what other people say, as well-meaning as they may be, about the alignment of your lumbar spine, about the curve, about the hyperlordosis, about the pelvic tilt. Ignore all of that. It's worth nothing. It's worth less, right? When people are saying that, it's not only worth less, it's actually probably sending you off in the wrong direction because it's baseless, right? The reason people will tell Maya specifically that she has too much curve in her lumbar spine, and she might have heard this, and I know because she's live, she'll be able to comment, right? They say, oh, now they're actually cut off on the x-ray. This line here, this kind of line, this flat line, that's where the x-ray has cut off the person's body, essentially, right? Because it's not relevant, it doesn't need to see that. But we could probably infer that this line here is Maya's skin. And it's coming out, it might, maybe come out here and go around or something like that. What will have happened is someone said, oh, look, your bum sticks out here, and oh, that's very deep, and you must have too much curve. That's probably what was said, because that's said to everybody. The bum sticking out over here is immaterial. We don't start measuring the curve until we get to here. And it just goes to show the fact that some people just don't have this experience. And if you don't have this experience, you don't know what you don't know. And so you go around telling people to do posterior pelvic tilts, and it's not helping them at all, at all, at all. And so all of this to say that Maya, specifically with her x-rays, actually is set up pretty well, right? She should be aiming for about 30 degrees in curve, 30, which is this number here. She's got, and she should have a 30-degree sacral base, which is basically the pelvic tilt. She's got 30 degrees of sacral base here, and she's got 34 degrees of curve. Perfectly happy within normal limits. The only area we could be a little bit picky is if we said that, oh, well, she's got a bit of a hinge point up here at L2-3. It's 12, it's bending backwards a little bit too much. And down here at L4-5 is a little bit flatter than it otherwise should be. But other than that, and again, so Maya said here, yes, they told me I have lumbar lordosis. Firstly, when someone tells you, if a practitioner tells you you have lumbar lordosis, say, in other news, I've also got 2 arms, right? Thanks for that information. It's completely and utterly useless, right? It's completely and utterly useless, right? The statement itself is so naive. They might say you've got reduced lumbar lordosis. They might say you've got increased lumbar lordosis. Those are both valid statements. But to say you've got low lordosis, a human spine should have lordosis. How much it has might be a topic of discussion, like it is here today. And we can see in this particular scenario, if they didn't know that there's some slight caveats to what a normal might need to be for Maya, Maya actually is sitting with a reduced lumbar lordosis relative to the normal for the average. Now we've changed that, right? Because the average, generally speaking, the normal lumbar lordosis should be 40. She's down at 34. So even in that scenario, she actually, even if they didn't know the extra bits of detail for her specifically, they're saying she's got an increased lordosis. She does not. She does not have an increased lordosis at all. And so again, it goes into showing the inaccuracies of a physical examination. But really, I round off this bit, and then I'll go into some of the comments and questions to say that this is such a great example. Maya's got good structure, right? She's got a good lumbar curve, sat on a good sacral base angle or a degree of pelvic tilt. And she's got a minor disc bulge at L5S1 that unfortunately has been managed very poorly over the years preceding joining the program. But now she's doing the right thing. She's doing the right thing. She's making progress. We're up to, I think, if memory serves, around about 25 to 30 kilos on the squat or hip hinge, squat and or hip hinge. And we're starting to actually rebuild a degree of strength and resilience. And we're pushing on with that. So for all of you guys that haven't had any imaging, it's not to say you need to go and have imaging, right? None of this changes what she needs to do. It doesn't change any of the rehab stuff at all, because the rehab is not on this. It's based on how she was when she started. She will have had to do different modifications as she's gone through the process of doing the exercises, the dead bug, the marching bridge, the squat, the hip hinge, the step up, the single leg hip hinge. And she might have had a bit of trouble with the knee on one side. So she's had to divert over and focus a bit more on the hip hinges for a while so that the knee can catch up. And then we've been able to bring back in the squats. That's where the uniqueness lies. It lies in your process through the rehabilitation program, not through the nuance that might well be evident on the MRIs or on the X-rays. We can talk about that. And as hopefully you guys have seen, there's a lot more to talk about on an X-ray than there is on an MRI that is usable for the individual understanding their alignment, et cetera, et cetera, et cetera. So I hope that was helpful. Mia, any other questions, just post them in the comments. I'm going to go through some of the questions and comments that are still up now, but I do still have those X-rays there. So if you guys have any questions, Maya specifically, let me know. I'm just going to remove some of the scribblings on there, and then we'll get into the questions, guys. Have a look at what else is coming in. So let me go to the top so I don't miss anybody. Okay, should you train even if you're suffering with back pain, or do you need to wait for the back pain inflammation to subside? You should be doing rehab even if you've got back pain. Training is different, right? Now, training might well be rehab depending on where you are in the recovery process, but you shouldn't really be readily wanting to drop out your rehabilitation work, because much of daily life, it depends on where you are in the recovery process, right? So if you're early on in the recovery process, then you certainly do not drop out your rehabilitation work just because you're in pain, because most people join the program in pain. And so you work with rehab. And I was only speaking to someone the other day, going through the bit of back and forth, and it transpires that the only time they are reliably not in pain is when they're doing the exercises. Why? Because when you're early on in the recovery process, the only time you're actually paying attention to your lower back is when you're doing the exercises. And most of the flare-ups happen outside of the exercises. And so the exercises, the rehab, is the safest time of your day. And what's more, sometimes if you're having a flare-up, it causes you to take a step back and reevaluate whether you've been as specific with your exercises as you otherwise could have been. Because sometimes you're not being as specific and as focused as you need to be with your rehabilitation exercises, such that you actually get an opportunity with increased sensitivity to refine your technique during that flare-up. What else have we got here? Tara said, this sounds very similar to my circumstances. My MRI from about 10 years ago showed a minor bulging. I used the classic advice. The most recent MRI showed an extrusion. I wish I had known then. I would have saved the world of pain. I mean, the most important thing, it sucks, you know, when we get this sort of scenario, Tara and others who will probably be in similar scenarios. We get it all the time. You know, I wish I'd known this before. But there is a proverb, I think it's a Chinese one. It says, the best time to plant a tree was 20 years ago. The second best time is today. Don't persecute yourself for making mistakes that were innocent. The most important thing is that we move forwards purposefully. Yeah, I mean, that's a fair statement, Max Gamer. Lewis Martin, what about if you already had strong legs and then get a disc bulge? In theory, shouldn't you already have strength there? It doesn't stop you getting an injury. And yes, you should. But if that doesn't stop an individual, I just mentioned a moment ago at the start, Lewis, you might not have been with us. The guy I was talking to with his herniation that I train with now, jiu-jitsu, right? He's back into it. Significant herniation is someone who used to squat, I think a squat or deadlift, 300 kilos plus, right? You can be, it doesn't stop you from getting injured. You can still get injured, right? In a lot of cases, those sorts of scenarios, the injury is that you pushed yourself too hard in one way or another, right? We've all been there, those of us that have trained regularly, where we've been partway through a squat set and we're going for the extra rep, right? We're doing maybe strength training at sets of 3, sets of 2, maybe even. Maybe we're doing a deadlift and we're coming through and we round that lower back a little bit and come, like everybody's been there, right? Everybody's been there. When you are pushing the envelope, especially at a high level, you can injure yourself. You certainly can. You certainly can. But yes, if you catch it early, if you've just injured yourself, maybe at the gym, right? Maybe you were going for that personal best. You were going to go and squat 185 kilos for the first time and break your personal best of 180 kilos on the squat. And you happen to bury that rep and you go too low, you round your lower back and it goes. Sorry, you know, it's no different to going skiing and going around the bend too fast and your knee giving out, right? If you are doing something that's pushing yourself to the limit and you go beyond that limit, you can still injure yourself. That's reasonably, being strong doesn't mean you can never get injured, but it means that bending down to pick your socks up is not going to be the thing that causes it to go. Now, if you've already got the injury and you are still strong, then that can be a factor, right? For sure. You know, the person who's injured their back and they've just herniated a disc or whatever it may be, they're going down to put their socks on in the morning and it's terribly sore, terribly painful, right? Hopefully that makes a bit of sense. So Amadi, best place to get help and support is on the program. Check out the link. You're on Instagram. Check out the link on the profile page. Is there a preferred squat method? The front squat or doing back squats? I personally prefer the back squat. I think the front squat is personally, you can have your own opinion on this. Those of you guys that are a bit more informed in that regard. I think that the back squat is a lower bar for entry in terms of technique. And I think the front squat is a little bit more challenging for most people to learn. That might be my personal experience as well. And so I'd be tempted to focus on the barbell back squat. If you were someone who wanted to use the safety bar, those of you in the bodybuilding space or who have experience working out in the gym will know what that is. That's perfectly reasonable. I wouldn't suggest that's a problem. It's still a free weight bar to use, so that would be okay as well. I just think the front squat is a bit too technical, and the problem with you're going to start folding forwards, or if you're holding it like that, I can't hold it like that, folding forwards, and now all of a sudden you're folding forwards from the top. I think you're better off going with the barbell back squat personally. Lewis has said on the so I sent you a video in the membership area, hip hinge. You mentioned my spine was rounding slightly. Could that be because my shoulders aren't pulling back enough? No, well, so one of the things that helps you from not rounding your lower back is if you really get a strong chest pop in at the start, and then as you go down and you hit that bottom point. And so, yeah, engaging the lats as well to create that extra layer of support is helpful. But really, it's the fact that you're just going through the lumbar spine. In that particular example, you're just allowing the back to bend, and that needs to be refined out. Definitely using the tape test and recording the tape test. Like literally get someone, if you can do this at home. You don't need to do this at this part at the gym. And literally get someone to stand behind you, recording your back, so they can see your back there, and they can see the tape. So just take the top off and do it, right? So you can see the tape as you go through the hip hinge, and go too far, and then go to the right level. And this is going to help you actually get an awareness of the right depth on the hip hinge that you should be going to effective to really refine your technique. The tape test is so underrated. It's free, right? It's packing tape. It's not kineso tape or no special physio tape. It's just normal tape that you would put to send a parcel, to a friend, right? It's nothing complex. But the nice thing about it is the tape doesn't stretch. So when you stick it along the spine here, you have to obviously stand straight to start with. If you don't stand straight to start with, then it's not going to work, right? But when you stick it on your back, it'll dip into all the crinkles, right, of the loose skin there. And then so as soon as you're going through the hip hinge, if you're videoing it, you can see the light flickers off it and you can see it starts to straighten out. And you see this going, and then it'll pull off. And that gives you that extra bit of guidance, because when you've injured your back, you've injured the segments here, which give you feedback from a proprioceptive point of view, right? This area, proprioceptive information is coming in here from what's going on in this region. So it's very, very normal for you not to be very good, very aware of what's going on in that area of the lower back. And so this is a nice little tool that you can use to help you see what's going on. I call it like having a reversing camera or sensors on your car. It just gives you that extra bit of information. But Lewis, the squat was definitely your strength, I think. I think really progressing on, Lewis, specifically with the squat and having that hip hinge is something that you're working on really refining. I think it's going to be a good way just for the, I don't think it take that long, but I think it's really important. And again, this raises interesting things, because I know you were doing a bit of heavier weight before you had a flare up, right? And so, we're obviously seeing some kind of errors that may have been creeping in before when we were doing heavier weights, which again goes back to, well, what if I was doing a heavy squat before, heavy squat, and I injured my back? There are a lot of people in the gym doing things with weights, significant amounts of weights, that they are getting away with. I could tell you that they are getting away with doing those things. It's not an operation for success, I would suggest. Holly says, how can I upload memory image in the members area? Holly, you just post them in there. Mina said, thank you so much, Mike, for taking this to today's live session. I would have still been bedbound if I hadn't started the rehab program, as I had been receiving the wrong advice and therapies for 7 or 8 years. Thanks again. It's a pleasure. And thank you, Mia, for sharing these, because hopefully it's really helpful for you, but also for so many others, seeing the images and like understanding, what we're saying and why we're saying it. Particularly, I think, just that realization that you can have objectively a relatively minor injury, and you can have a relatively well-aligned lumbar spine and be struggling quite considerably when you just get the wrong kind of guidance, the wrong kind of advice. What else have we got? Let's just come through, have a look at what have we got in here. Hey, I've just seen a surgeon. This is Andrew. I've just seen a surgeon. I've got a herniated disc. He's recommended an injection. Why? This is not a criticism of Andrew at all, right? So what's happened here? Let's talk this through with everybody, right? What is a herniated disc? And I assume Andrew's in pain of some description, maybe back pain, maybe sciatic pain, maybe a bit of both, right? So you've seen the surgeon, and the surgeon's gone, we've got a herniated disc like this. Okay. What is that? That is a damage to the annulus, because that bit in here, this light gray bit, only got out there by breaking through these layers. These layers have been broken. That's what you have. So what we've got is we've got a disc injury that has allowed the bulge to be there, and the surgeon is suggesting an injection. So that means he's not worried about what that's pressing on. That's what he's saying first and foremost. He's not worried about what that part of the disc is pressing on. Thankfully, maybe it's not pressing on the bundle of the quarter-equina bundle. So that's happy days, right? But he's not giving any guidance whatsoever to help with the healing and recovery process here at all. Now, he might be doing a diagnostic injection. That's something to bear in mind, Andrew. It might be that he's recommending the injection for diagnostic purposes. Maybe he's saying, I think it might be coming from here. It might be coming from here. So we're going to inject it. If the pain goes, then we can deduce that that is where things are coming from. And that he might have discussed that with you, but I'd suggest you would have commented that maybe, although you are limited on character count, so maybe that extra detail wasn't allowed, let's say. But the important thing is you've got to do something to support the spine. You've got to start your rehabilitation work, right? You've got an injury there. You have an injury in the junction between two bones. The ligaments have been damaged, because that's what these are. These are ligaments, the annulus fibrosus. And so we need to set about a plan to support that area, protect it, so it can go through the appropriate recovery process. That's what we do in the program, right? And those of you guys are on TikTok, those of you guys are on Instagram, etc., you guys can just check out the links in the profile page or send us a DM or whatever, and we can send you a link to the right place. Joe says, I've got a bulging disc at L3, 4, and 5, as well as DDD, kind of one in the same fundamentally. Leaned over too far, and now I've got a fizzy feet. So what we've probably done here in this sort of scenario is we've gone over like that, right? Rounded the lower back, squashed down on the front of those discs, and boom, we're there. Andrew, we have the program, the Back in Shape program. The link in the profile page, or just send us a DM, Andrew, and we will send you a link to a page on the website which gives you a video that explains a little bit more about the program, shows you guys inside, etc., etc. That'll be what that'll help you. What is a bulging disc injury? So your disc should have the nucleus pulposus, which is the fluid bit in the middle, and then hopefully you guys can see it. Get my face out of the way so it focuses. There we go. You can see there's layers here, right? And so you've got a bunch of layers that are arranged roughly perpendicular to one another of the annulus fibrosus. And that means that it's got strength in all directions. It can absorb shock. The way in which it absorbs shock is that you've got a fluid center and stretchy ligaments that run around the side, strong, stretchy ligaments. So when we squash down, the ligaments can stretch a little bit. Think of a water balloon or a balloon in general, right? As you press down, the edges stretch a little bit and then they spring back. Normal function. We can move in all sorts of different directions. It's fine. When we have an injury, such as the bulge, because this thing is under load every single day, we have the strain in the ligaments and it breaks through one or two of those layers, maybe two or three, etc., on its way to the full-on herniation or sequestration, where it goes all the way out, right? You get the idea. And because that has taken place, this quadrant here of the disc, the back right quadrant of the disc, now has fewer layers to stop that disc from escaping, that fluid to escaping. When it's like this, all of the directions, all of the quadrants have a nice strong set of ligaments blocking them. So when you squash down on the disc in any direction, it's kind of strong in all directions. But when you squash down now on this disc, there's this quadrant where the fluid wants to go that direction. So the force is going to try and go in that way, let alone if we bend forwards and lean to the one side, then it really focuses strain on this area here. And that's then where we have this bulge, right? It deforms a little bit more under that loading because there's less wall in the way of the fluid coming out. And then obviously that progresses on and on and on, depending on whether we allow it to knit back together again and strengthen up or not. What else have we got here? We'll come back to the comments on YouTube. What's here? At what stage in your rehab can you start safely adding back other athletic hobbies? I presume that's when, yeah, I'd typically say as you start getting back into like 40 to 50% body weight on the squats or hip hinges, that's when you can start to consider those kind of things. Again, it depends on what exactly you're looking to get into, because that's going to slightly skew that measure. If you're looking to just, get back into, playing around in the garden as we get into spring, hopefully sooner rather than later, you might need a little bit less than someone that wants to get back into jiu-jitsu, right? What have we got here? We got Mason Filmer said muscle guarding from a car crash, work, etc. Doing some rehab. Mason, my best tip would be get into the program. All the stuff we're talking about is relevant. It's going to be relevant. But get into the program. Mitchell has said, how often would you do back-related exercises, squats, hip hinges? It's 3 times a week, excessive. It really depends on where you're at in the recovery process, right? If you've just started doing your back rehabilitation exercises, then you should be doing them every single day. That would be like the phase 1 and phase 2 people for the Back in Shape program. If you're further on and you're doing a reasonable amount of loading, then you might only be doing heavier sessions, maybe 3 or 4 times a week. And then long term, as you get to a heavier level, you might only be doing like 1 or 2 sessions that are heavy each week. And that really is something that depends on your recovery capacity, right? And it's a different point for each individual that you get to the point where you need to drop down. And it might be that actually that needs to be factored in with what are you doing in everyday life, right? If you're absolutely under the pump and you're busy and stressed out with work and you're like trying to continue to progress things and you're up at maybe like 70 kilos on your squats and hip hinges, now might not be the best time for you to try and make an extra bit of progress, right? And push yourself too hard. You might want to drop down the frequency with which you're doing the heavy sessions, just because your life is not set up for recovery right now, because you're working to finish this project with a deadline in 3 weeks' time. So you need to play, as you get further on in the program, you need to be a bit more strategic with these kind of things. Incorporate everyday life stuff as well. That's the kind of stuff that we help members with in the program. As you get to that point, thinking a little bit more strategically about total strain in the body. I used the example from a couple of years ago where I was digging out the driveway. During that fortnight process where I was having to dig out dirt from below ground level and fill it into an 8-yard skip, which is quite a large skip, just chucking it right from below ground, not very good for the lower back. That week, that fortnight, sorry, I wasn't pushing myself at the gym or at jiu-jitsu. You have to be strategic. People often don't do that. They try and do both at the same time, and then they fall foul. Tara, we've done that one. Tara, Evelyn says, I am 76, late onset scoliosis, herniated disc, L5S1, acute pain in the heels, or anything I can do? No, you're not beyond help at all, Evelyn. You just do exactly the same rehab that the person who's 66 does, that the person who's 56 does, 46, 36, etc. Everybody has different things going for them, right? And nobody's beyond help. You're no more beyond help than the 26-year-old, Evelyn. You will have different things going for you. As a person with more years on this planet, you probably have a different perspective on time compared to the 21-year-old. You have a different level of patience, maybe attention to detail, etc., etc. And so some of the things that benefit us as we get further on in years, wisdom-wise, are not benefits for us in our younger years, when impatience can often be a factor. And so yes, the younger person who's 26 instead of being 76 might well be biologically set up. They've got less other confounding variables, etc. But they might be pursuing a busy career, trying to go out on the weekends and do all sorts of other bits and pieces, right? And that's going to be a problem for them. Evelyn might not have. I mean, you may want to do some of those things as well. That's fine, right? But chances are, Evelyn, you haven't got young kids. You might have young grandkids that you have to look after, but that's very different to having young kids, right? In terms of the level of involvement, level of required involvement, level of unavoidable involvement. You might no longer be doing the same kind of work that you were doing when you were 56, right? You might not have all of those constraints on your life. So there are many things that are going for the person who might well be in their retirement years, let's say, as a catch-all, that aren't going for the person that's in their middle life, that aren't there for the person that is in their early years, early adult years. And so no, you're not beyond help. You know, you're still going to have to get out of a chair. You're still going to have to move through. You're still going to have to dress yourself, etc. And what I would say, especially to Evelyn and others that are in that age bracket, you're seeing nowadays more and more on social media, people in those years, their 70s, 65 plus, who start the process of resistance and strength and training in their retirement years as something to do, right? And they build levels of strength that would put most people on the call to shame. The body doesn't stop working just because we're 76, right? Certain things might not work as well as they used to, but that doesn't mean you're beyond help at all, at all. And we also want to realize there are many things that are going for us in that stage of life. You've got, greater finances. That's something that's really a real thing, right? You've got greater financial freedom than the person who's 26 trying to deal with this. There's all sorts of variables. I think it's wrong to say that one age group versus another age group, have more of a hard time. Everybody has their own battles. And people that are 76 will also have their own battles in amongst people of that age cohort. YOLO says, herniated disc at L45 for 5 years, unable to operate due to heart condition and blood thinners. Do the rehab work, right? Do the rehab. What is the rehab work? Core engagement, dead bugs, marching bridges, squats, hip hinges, step up, single leg hip hinges. You're doing those things every single day anyway, YOLO. Getting out of bed, getting dressed, going downstairs, etc. Right? So start. No username, it says, as if on cue. I'm 32. I have a toddler, 15 months old, and a herniated L6S1, L5S1 maybe, of 6 mil. That's someone who's got I would argue, that's a tough time. Having to look after that little one who's running around. No one else is going to do it for you. Yeah, the other half can help out. Maybe parents can help out a little bit. Grandparents, sorry, can help out a little bit. But you're still under a significant amount of stress. In spite of that, acknowledge it, because it's important to acknowledge it. I really find it frustrating when a parent will come maybe into the members area, or they come into the clinic and say, I'm not doing anything. I don't know why my back pain's getting worse. And I'm like, listen, you have a toddler. What do you mean you're not doing anything? You're running around after them all day. You're having to pick them up, change their nappies, whatever it may be, depending on the age, obviously. You're not doing nothing every day. Take a step back and actually validate what you are doing every day. Because no one does nothing. Not even a tree does nothing. A tree does photosynthesis and it kind of sways a little bit in the breeze. So one of the biggest pet peeves for me is when someone comes into the clinic and says, I'm not doing anything every day. Right? That's not an answer. No one does nothing. You might not do a lot, but specifically state what precisely you are doing. Even if it's just rolling out of bed, spending all day scrolling on social media, and then going to the bathroom and coming back again. That might be it. That might be it. And to that end, just on those of you that are struggling a little bit more, because I was supposed to say this in the earlier part when we were talking about Myers X-rays. Even if you're that bad, because sometimes people say, well, I'm too bad to start rehab. If you're too bad to start rehab and you're genuinely bedbound, that's fantastic. You can lie in bed and instead of scrolling social media, you can do all of the learning. We have nearly 100 educational units in the education your back health section, which is separate to the program, the main core phase 1, 2, 3, 4, and the core relief work and the troubleshooting libraries, etc. Watch all of that. If you're really that bad and you can't do anything, watch all of that while you're waiting. Now, yeah, some of the painkillers and stuff you guys might be taking might make it a little bit more difficult, but watch that. Watch that. If you've just had surgery and you're like, I'm worried about getting involved in things, well, you're not doing anything else, so watch the educational material, because people don't value the educational material as much as they should do. The education helps you go, maybe that's not such a good idea, as opposed to just brazenly carrying on. Jose, I have an L5S1 disc bulge. Some people have told me that this condition usually causes pain that radiates down the legs, but in this case, I have localized pain in the lower back. Yeah, it can be either or both. And as you'll see, which confuses you even more, some people will have an L5S1 disc bulge and they won't have any pain. Go figure. The important takeaway is you've got an injury in your lower back. You need to rebuild the strength and stability. Even with that pain, I'm doing McGill Big 3 and some air squats and air deadlift. Awesome. If you need more structure, Jose, check out the program. What else have we got? Andre says, I have a 9.4 mil herniated disc. Doc said I should not go to the gym ever again. The doc is wrong, Andre. Ignore that doctor. Go over to YouTube and watch the start of this live stream, please, because we literally talked about that specific case in Myers X-rays and MRIs. We went through all of this stuff, right? Herniated disc down the bottom there, down here, okay? Or bulging disc in this particular case, sorry, not to misspeak. So ignore what your doctor said. That doesn't mean you go to the gym, right? I want to be clear. That doesn't mean you just go to the gym and do random stuff, but do rehab. But to say you should never go to the gym ever again is a massive, massive, massive overstep by your doctor, who quite clearly is extremely unwise or unthoughtful with what they're saying. Ignis says, this is exactly the live I needed. I have so many questions. Hopefully it's been helpful, Ignis. What could be causing neck traps extremely tight and tender? If you've got, so a lot of times your lower back issues first manifest as stiffness, aching, or discomfort around here, maybe going into the buttocks, maybe into the legs or thighs, and is often misinterpreted. I'm going to sneeze. Maybe not. Okay. It's often misinterpreted. No, it's often misinterpreted. Sorry. Sorry about that. I don't have a mute. I'm looking for the mute button and I need to maybe put one on there. Okay. It's often misinterpreted as stiffness. Thank you. Thank you, Ignis. The tension is often misinterpreted as a muscle problem. So we should stretch it more. And the same thing happens in the neck and shoulders. We often get stiffness and tension in this area. And so we stretch it even more. If this sounds like it might be relevant to you, we did a live session, I think it was maybe Monday last week, if not the week before. It's on the YouTube channel, where we talked about one of the ladies, Ella's neck x-rays, and we went through this in a lot of detail. The issues that affect the neck, the lower back, that we talk about all the time, constantly rounding and flattening the lumbar spine lordosis, constantly doing forward bending stretches, also are exactly the same issues we see in the neck. How many of you, even right now, are something like this, massively flexing the neck? Lie in bed with the head propped up, watching things, right? How many of you are doing that right now while we're doing this? That's why you've got the tension there. Those muscles don't need to be stretched even more. You are likely irritating the neck a little bit here, the cervical spine, and you need to take the pressure off, not stretch it more. You take the pressure off, a great little one, just like we have the towel for the lower back, we have the little towel for the neck, just supports the neck curve, takes those muscles off tension rather than stretching them more. Very, very common mistake, misunderstanding. Pav says, how can I have surgery when the doctors don't know which side? That is a very valid question. I could just remove the whole thing, right? But no, I'm being a bit facetious there. No, you need to do the rehab. You need to do the rehab. Sam says, and this is a great example. Sam has a bilateral pars spondy, grade 1. He's also been told he has an annular tear down there. I know the spondy can't be fixed. What about the tear? If you have a spondylolisthesis and we have, for example, a pars defect, that is not the problem. I repeat, that is not what is causing your pain. The spondylolisthesis slides forwards, and that puts the soft tissues, of which the annulus is one of them, annulus fibrosis, under extra strain. It is the annulus fibrosis. It is the ligaments in between the vertebra, interspinous ligament, supraspinous ligament, ligamentum flavum, the facet joint capsule, and other ligamentous structures that actually are the things that are causing your pain in the case of the spondylolisthesis. Those structures have more demanded of them. And so often we get people like in Sam's case where they have the injury to the lower back. They go and see one guy, he talks about an anterior listhesis, right? Spondylolisthesis going forwards. And we see another one and they talk about the annular tear. And you guys think that they're talking about a different thing. They're talking about the same thing. They're talking about the same segment, right? The spondylolisthesis is present, yes, but it's probably been present there for a long period of time. It's very, very rare that a patient will come in to the clinic with a spondylolisthesis and with a appropriate medical history that would suggest they caused the spondylolisthesis in some moment, i.e., they didn't fall off a ladder from up there. You guys can't see it, but you know, that's what, maybe 12, 13, 14, 15 feet. They didn't fall 15 foot, land on their back and go, boom, my back pain's come on for the first time after that. Now, that's not to say it couldn't be, right? But most of the time, that's not the onset. And so we can deduce generally that there is nothing in recent history or past history, longer history, that would explain the sudden presence of a spondylolisthesis. And what we can therefore infer is that there is more likely the pars defect that has caused the slow slippage over time. This problem with the spondylolisthesis is it puts a more pointed strain on the soft tissues. And so if you injure them, they are under more strain while you're trying to get them better. So don't get confused, Sam. It's the same thing. And yes, the annular tears go through a healing process. That's fundamentally what everybody is doing when they have the herniated disc. For example, on today's live session with Maya, she had the bulge disc in the lower lumbar spine at L5S1. That is what is healing when she increases the loading as she goes through the rehabilitation work. Where are we doing for time? Oh, we're going good. We're going good. Thanks, Mike. I have long term to come back through some of the comments over here on TikTok. For me, what is strange is that I don't have any pain. I just feel that it's holding me back. No numbness. Okay. Ignace says it hurts. It hurts when you put the bar on the top of my back. So when doing a barbell back squat, often you'll get those pads in the gym. Just seeing if I got one in here. Do we? Oh yeah, here we go. Just use one of these or a towel. Just got a bar pad, right? And just wrap that around the bar. Or you can wrap a towel. Just take a towel into the gym, wrap it over the bar, make it a bit softer. Generally speaking, I would suggest you shouldn't really have the bar. I mean, it depends on the level of muscularity of the individual. And this answer is not necessarily appropriate for a lot of people. But if the bar is resting right here on your neck, it's likely to be resting on the C7-T1 vertebra, which is not going to be a pleasant experience. Any more than leaning on your elbow on a metal surface here is going to be unpleasant, right? You're just not going to want to do that. So the answer for most people is build stronger trap muscles and bigger trap muscles because they should provide a nice cushion for the bar. The other thing to bear in mind is the bar should be a little bit lower down, I would suggest, especially if that's a problem. Just move the bar down a little bit so it's on the meat of the muscle here, so that it's not causing as much pain. That's, I think, a better long-term solution. But the short-term solution is, yeah, use a pad, use a towel. I would say a towel might be a better option because that way you can just get the minimum necessary to make it a bit more comfortable without having a pad. Because sometimes it feels like it's, you know, there's a layer of jelly up there and it's wobbling all over the shop on your back. So the pad might not necessarily be the best option if you're happy to use a towel. And so Ignis, in that scenario, it's a double case of building a little bit of back muscle if possible, which will happen anyway over time if you're doing the right work, and using the towel or the pad a little bit. Also, it is something you kind of get used to as well. I always remember like having a period. I just remember that period during COVID where we had like 3 months off. Like I'd never ever had that kind of time frame out of working out, period, like completely. And then getting back in and just putting like a little bit of weight on the bar on the back of the shoulders, like it's uncomfortable. You do get a bit used to it. So that's something to bear in mind as well. Generally speaking, the size of the operation, the size of the herniation is not necessarily, sorry, the size of the herniation is not necessarily the indication to do surgery or not, really. But if they're saying that you're close to the point, this is for Andre, if you're close to that point, they're implying you're not at that point. And so what are they going to do? Just leave you like, they've got one or two choices. They either send you home or they leave you there and try and force it to get worse. Like that's a really, really poor thing for them to say. You say, well, you're close to the point where you might need an operation, but you're not quite there yet. It's like, okay, thanks. And then what do I do about that? Well, sending you home with no instruction is a great way to increase the probability that it gets worse. That's for sure. They've told you to wait. Of course you're scared. You're scared when you get told that. And they've literally told me to wait. That is the worst advice ever. Absolutely terrible. Wait until it goes bad. Yeah, go and see, like, it's so unfortunate. It's not laughing. It's not a laughing matter, but if you don't laugh at it, then I don't know what you do. You know, do the rehab. Do the rehab. Acknowledge that, you know, maybe there is a case that it gets worse, but there's also a case that it doesn't, right? Bearing in mind a significant number of operations don't need to have surgery. Sorry. The majority of back injuries, of herniated discs, of bulging discs, etc., do not need to have surgery. That's an important thing to bear in mind. The things that you are doing at home that the surgeons have knowingly sent you home, right? Knowingly sent you home, that you're doing, right? You're getting out of bed in the morning, you're going to the bathroom, right? You're doing a number of other things every single day. In spite of the fact that the disc bulge is there, start doing some rehab. Start actually doing something that's going to control and stabilize that area of the lower back better so that you become safer with each passing day. Because the body is trying to heal at that level where you've got the herniation every single day, right? And you're young. If you're 21, you've got time, right? But at the same time, we can't sit at home. I have no preconceptions, but I'm just thinking, right? When I was at university, I played video games. You can't be sat at home playing video games. Sat like this. You know, we've got to make sure we're not doing that kind of stuff. That's not to say you can't play video games, but like just thinking about how you might be using yourself each day is why education is so important. Robin's saying about having a very bad experience with surgery. You know, everything is a risk. When you start poking things into the body, it is a risk. Now, by and large, you know, it's important to be fair. These things wouldn't be there if they didn't help more people than they harm, I would suggest. You know, but they do need to be selected for and done carefully. You know, we don't have the details of Robin's, right? But generally speaking, those that have had successful surgery aren't necessarily on social media talking about it. They're not aware of it because they've done it and they moved on, right? But it is a risk, and it's a risk that should be fully communicated to you guys. And that's the problem, right? With Robin, right? You don't know how badly things can go until they do. And that's often not communicated. MMR, it says, I've got anterior pelvic tilt. What can I do? Check you've actually got it, because most people don't. And we discussed this. We'll just come back for everybody's benefit who hasn't been on the live at the start. We went through Maya's x-rays. She has been told time and time again that she has anterior pelvic tilt. And we've measured the degree of tilt. The anterior pelvic tilt is a surrogate to get an idea of what slope the sacrum is sitting on, right? This here, this middle image, where I will eventually draw on the computer. There we go. This is the slope. If you anteriorly tilt the pelvis, the slope gets steeper. If you posteriorly tilt the pelvis, the slope gets flatter. Anterior obviously creates more shear, posterior more compression. But the point is, she has a technically posterior pelvic tilt to anyone observing from the outside without the extra context that we discussed at the start of the live stream, which I won't bother going into detail on. She has a technique, but she has been told time and time again that she has anterior pelvic tilt. Why? Because her bum sticks out and her lower back is in. Most likely that's why, right? And we got her to check with us live if she'd been told, and she said yes. I don't know if Maya's still here or not, right? People go around telling people I have pelvic tilt based on a physical examination all the time, and it's wrong. It's incorrect. And now MMR is trying to fix his anterior pelvic tilt that he probably doesn't have. Because most people, get this, actually have normal alignment. And the comments of pelvic tilt are based on very flawed physical examinations. David says, what are your thoughts on McGill back rehab exercise? I think a lot of our stuff crosses over with McGill quite closely. But people often talk about the McGill Big Three as being a complete back rehab, and they're not. And I don't know that if you actually spoke to him, whether he would necessarily suggest that they are complete back rehab. But they are inferred as being complete back rehab. Oh, I do the McGill Big Three to get better on my back. It's like, no, that's not a complete back rehabilitation solution. It has no component of spinal loading in it. I think there are issues with duration holds. And I've seen a good number of individuals teaching the McGill Big Three and teaching it incorrectly. One classic example is I think they're called the curl up, something where you're lying on the floor and you've got your hand behind your back, right? When he teaches this, he teaches about preserving the lordosis when you do that, right? Which is a very important teaching point. People online teach it by flattening the lumbar spine into the ground. That's wrong. You're not supposed to do that. That's not the cue. That's not the cue at all, right? And so that's worth bearing in mind. Secondly, little things bug me. Why are you putting your arm behind your back? And that is a McGill instruction. Why are you putting your arm behind your back, right? Often people are quite sensitive to little movements when they have a lower back injury. They're quite sensitive. Some of you guys watching right now might be quite sensitive to little movements one way or another when you have your lower back injury. Is my forearm the same here as it is here? No, it's on a sliding scale. So will I, when I lie with this underneath my lower back, tilt myself to one side? Is that helpful? No, probably not. What is better is using a rolled up towel placed in the middle, right? Little things like that people don't think about. I mean, he's a very, very, very well researched, very intelligent guy. So, you know, little things like that maybe sometimes aren't bothered, aren't caught in the net, right? But little things, right? Why not just instruct to do it with a towel underneath the lower back? Make it so much easier. It's not like a towel costs anything, right? Everybody's got towels lying about the place, but it would just make it more symmetrical as you're doing that. Just something to think about anyway. And I think there's better uses of your hands when doing an exercise like that. So a couple of things to think about there, but a lot of what McGill talks about runs in agreement with a lot of the things that we talk about. To answer the question. Oh, that's cool. Ty, thanks a lot. I didn't see that. That's really cool. So Ty said, as I said above, I herniated my disc twice and your program helped me healed 100%. That's awesome. I'm glad you got the result. The important thing is to remember that we must continue to do the rehab long term. And I think on that one, we'll wrap it up for today, guys. Hopefully it's been a helpful one for you. Hopefully the screen share was helpful as well. Those of you guys that are still with us on TikTok, on Instagram, if you need more help, more support, just send us a DM on those platforms. Just let us know, right? Just let us know, and then we can point you in the right direction. Same thing for those of you guys on YouTube. If you're still watching, or if you're watching the replay, just send us a comment in the comment section. And Zed says, I tuned in after seeing the email for today's live. Sounds very similar to my situation, except I was in my early 20s. Yeah, that's a tough place. I've since been disabled in a wheelchair with a walking stick. Not good, not a good place. Anyway, I hope it was helpful. If this is your first time joining, like Z8139, and like others, guys, hopefully this was helpful. If it was, you know, consider sharing it with someone else that you know. We will next be going live on Monday, I think, next week. And we'll see you guys there. Have a great weekend. Guys who need more support, you can DM us. Those of you guys that are members, post in the members area. That's where we are to help you guys each and every day. And we'll see you guys on the next live. Take care. Thanks for joining.